Hello everyone, this is Schwatrz, this is SIF 22. With me is Dr. Jonathan Schwatrz. He is the Medical Director of Interventional Cardiology at Sanger Heart and Vascular, Atrium Health. Jonathan, always nice to talk to you.
It's great to be back.
It's been a year.
Yep.
We were talking about COVID and structural heart last year.
Thankfully we're past most of that.
Exactly, yeah. So now it's up and coming now. The new space for structural heart is becoming the tricuspid. So kind of keep us up to date with what's going on.
Yeah, so very exciting. The Triluminate study, which is a modified version of the MitraClip, basically the same structure, just a little bit, the delivery system's a little bit different, is close to finishing enrollment, which is great. We don't have any results yet, but we're very hopeful that it's going to look great. And so we are not only participating in that, but also there's an imaging sub-study part of that, where patients, if they opt in, they get both a CT and an MRI pre and post clip. And that has really shown some interesting, very quantified results of just how much regurgitation you're affecting. And you have to assume that the outcomes will kind of follow the outcomes.
So which patient gets referred for these procedures?
Yeah, so pretty open. Patients, even if you have pacemaker leads, you can still get referred. It's severe TR or worse with symptoms that have been optimized on medical therapy and are still having symptoms. And that can range from just having dyspnea to edema to heart failure exacerbations, pretty much anything in between. Things like any kind of congenital things are being excluded from the trial for now, but if the anatomy looks clippable, so a TE is done, the leaflets have to be close enough that the clip is able to reach both leaflets, but most patients, the screen fail rate is relatively low, I think. I don't have exact numbers yet, but we'll see that soon. Not every patient is great for clip, but the ones that are, it seems like it's working great.
And they do well with the symptoms, specific symptoms.
Very much so.
So we saw a couple of talks about ICE and structural heart. Mm-hmm. I know it's not, in interventional cardiology, it's not too much as compared to EP, but it's up and coming. So tell us about where are we now? Yeah,
so ICE has been used a lot in Watchman lately, and it's gaining strong traction in tricuspid as well, particularly just because the tricuspid valve is so hard to image, even with TEE. Sometimes that's a limitation to getting in these trials, is you just can't visualize the leaflets as well as you need to. And so 2D ICE has been employed usually in conjunction with TE, sort of as an addendum. There's a lot of places that we're now able to do Watchmans solely based on ICE, which is great because that gets rid of anesthesia from the room, speeds your procedure times up, recovery's a lot faster. The latest thing coming out now is 3D, 4D ICE, depending on how you want to define it. Both Siemens and Philips have systems out. We've tested both of them, and they look like they're going to be great. They each kind of have their pros and cons and things that they're good at, and so I think there's some work to be done there to see what role each is going to play, but I anticipate that'll be the future.
And how's the learning curve for ICE?
If you've never done it before, there is a bit of learning. The images are relatively concordant with echo images. The harder part is just getting those images. So if you're able to visualize what you need, you usually can interpret it pretty easily, just because we're all used to doing all these things under transesophageal echo guidance.
The trick is to get the image.
Getting the image is tricky sometimes. Usually the reps are in the room for these studies, particularly when you're still learning how to do it, and so they can kind of walk you through it. There's some great online resources for this, and so it can be a little bit daunting if you've never done it before, but a lot of us are already using ICE for PFOs and ASDs, and even if you haven't jumped to using it to Watchman and tricuspid, a lot of the views are similar, and you're pretty used to navigating the probe, and so there's a lot of...
And that will eliminate intubation for the patient, will be conscious sedation.
Exactly, yeah.
Wow. Which is a big thing.
At least for Watchman in particular, tricuspid we're not quite there yet. I think we're still, the whole field is still learning about, is replacement going to be better for that? But I think long term it'll be great for patient care.
Absolutely. And in terms of imaging for the tricuspid, is there a role for CT or is purely sonography?
Yeah, so I think we're going to find that out with the imaging sub-study part of the Triluminate study as well. So we're also enrolling in the TriSend study, which is the Evoke valve from Edwards. Those patients all need CTs ahead of time just for sizing and making sure that you understand the subvalvular structures. I really do think even in repair cases, the CT is going to be quite helpful. It just allows you to visualize the leaflets a lot better. The tricuspid valve is a lot less standard than mitral. Sometimes you have quadricuspid leaflets and clefts and things that you just can't visualize that well on echo. And so if it's proven to improve outcomes, which it probably will, I think it'll probably become standard.
Absolutely. Well, like a lot to learn. So like tricuspid now just not pushing you to do the clips only, replacement, and now the imaging component is really pushing it there.
Exactly, and seeing, that'll be really key, is seeing is repair better, is replacement better. It's a wide open field. So.
Jonathan, always nice to talk to you and get update about structural heart. Thank you so much for your time. Please watch these videos and others on SIF YouTube channel. This is Schwatrz from SIF 22. Jonathan, thanks so much.
Great to be here.